get started this afternoon. And first up, I will have Revisor Scott Abbott give us a briefing on House Bill 2734 that we're holding hearings on today. I would welcome you, but I've already done that.
Thank you, Madam Chair, and good afternoon, members of the committee. House Bill 2734 concerns the Behavioral Sciences Regulatory Board and a couple of professions that are regulated by the board. The bill would amend provisions of law related to specialist clinical social workers and addiction counselors. Section 1 of the bill amends provisions of law related to social workers. You'll see it on page 2. Current law requires for a license for a specialist clinical social worker that they have completed a graduate level supervised clinical practicum of supervised professional experience. The bill would allow as an alternative to that other additional postgraduate supervised experience as determined by the board. The second change the bill would make is beginning on page 4. This is to licensure as an addiction counselor. The bill would allow a person who is currently licensed in Kansas by the board as a master's level or clinical level professional in another profession to apply for licensure and take the examination required to become licensed as an addiction counselor. Madam Chair, those are the changes the bill would make. The bill would take effect upon publication in the statute book or July 1, and I'd be happy to stand for questions.
Thank you, Scott. Committee, are there questions for Scott? As usual, great explanation. Thank you, Scott. All right, first up, I have as a proponent David Fye, the Executive Director of Behavioral Sciences Regulatory Board. Welcome to committee, David.
Thank you, Madam Chair. Members of the committee, my name is David Fye. I'm the Executive Director for the Kansas Behavioral Sciences Regulatory Board. Appreciate the opportunity to come before you today and provide a little more detail and offer proponent testimony on this bill. House Bill 2734 was requested on behalf of the BSRB. It does include 2 items that Scott mentioned just a little bit ago. One thing is the BSRB is the licensing body for most of the mental health professions in the state. And this bill, while it is a small bill affecting 2 items, it is important. We think it addresses some workforce issues, and it does not do any damage to the public protection mission of the board. Just to clarify a little bit, the item that Scott mentioned in terms of the social work profession, last year the BSRB requested a bill, House Bill 2208, and that bill did pass, and we appreciate your support of that bill. The final version of the bill had an amendment to some of the statutes affecting social work. Previously, there was some language which allowed the board to, you could look at someone who had taken a clinical practicum, or you could evaluate other postgraduate experience as determined by the board. And there was an amendment that was put on the bill to remove a specific number of direct client contact hours within the clinical practicum, but it also removed that language allowing the board to look at other postgraduate supervised experience by the board. Our legal counsel has informed us that with that language struck, it limits the ability of the board to look at other types of practicums individuals have taken, such as administrative practicums. So we don't believe that was the intent of the amendment last year. We just believe it was an unintended consequence. So we would ask that you add that language back in, providing the flexibility for the board to review those hours. And just want to make absolutely sure that amendment struck the 350-hour requirement for social workers. We're not asking for that to be added back in. We're just asking for that language to allow the flexibility to be added back in the statute. The second item affecting the addiction counselors, as Scott mentioned, that would allow individuals, most individuals who have a license under the BSRB at the master's level or the clinical level to go ahead and use that license to take the test for the lower level licensed addiction counselor license. One thing I want to clarify about this item is that currently in statute, the statutes and the current existing law allows individuals at the master's level who hold a master's level license under the BSRB to take the test for the master's level exam. And it allows individuals who hold a license at the clinical level to take that same exam because the master's level exam and the clinical exam are the same exam. So that's already in law right now. So this is an extension of existing law. What has happened happened is some individuals who have wanted to become master's level addiction counselors have had trouble passing that examination, but they would still like to be able to become licensed to provide addiction services. So they have requested the BSRB give them the ability to take the lower level licensed addiction counselor examination to become addiction counselors. And upon review of our statutes, we don't have that flexibility. So that's why we're bringing that item to the legislature to ask for the flexibility for those master's level or clinical level practitioners to not only test for the master's or clinical level license, but to test for the lower level license if they so choose. And as I mentioned earlier, I think these are both going to address workforce issues, and they don't affect public protection in a negative way. So I would ask for your encouragement in passing this bill, and I'd be happy to answer any questions.
Committee, are there questions of David? Representative Wolfmore.
Thank you, Madam Chair. I'm probably not following this, so just correct me. So part of what this bill does, if they take an administrative practicum as opposed to a clinical practicum, that could count towards the licensed clinical if it's approved by the board, or is that, I might have misunderstood, is that not part of it at all?
That is the first part of it. Previously, but before the bill that got passed last year, individuals could apply for that clinical level licensure, and they could either have taken a clinical practicum or a different practicum. If they took the clinical practicum, there were a set of requirements. If they had a different type of practicum, we could still evaluate them under other processes and regulation. But with that language struck, now you have to have had a clinical practicum. If you had another type of practicum, we can't evaluate you for a clinical level license. So we're asking applicants who submit materials now to try to find a clinical level practicum, which is very difficult. So we're just asking to go back to the same level of flexibility that we had for those applicants before the bill was passed last year.
And this is hopefully to help with workforce also.
Correct. This should allow additional applicants to be able to be submit themselves for the review process to become clinical level practitioners. And so it is our hope by passing this, we will be able to have more clinical level social workers providing services in Kansas.
Okay, thank you. Thank you, Madam Chair.
Representative Reese.
Is this for anyone that is applying now to have the LCSW, or is this for someone who is coming from another state?
This would be for individuals who are applying now.
No, okay. So we're kind of moving away from a clinical license to more of a generalist kind of license, clinical license?
No, the emphasis is still on the clinical. It's just in the past, if we had individuals who had a different track, we were able to look at their qualifications and see if they still met sufficient standards to be a clinical level practitioner. So that was already an existing law before the bill that passed last year. And this is a smaller group by far than the number who submit with a clinical practicum. But there are some individuals, and it may be some individuals who come from out of state who had a different process. But we don't want to limit those individuals from applying, and if they meet the other requirements, which would need to be determined in rules and regulations, because right now, with the bill passing last year, those don't apply anymore based on where the statute is worded.
That's great. I totally love this because it does open it up. I know folks from other states, and we don't have the same kind of flexibility here, in Kansas. So, yeah, thank you, for doing that. Can I ask one more question? Regarding the second part of this, if you had an LCSW and you wanted to take the bachelor level addictions exam, you could do that with this bill?
If this bill passes,
Yeah.
yes.
And are there any courses that are required prior to taking the test, or you just take the test and see if you pass it?
So under the training for each of the master's level and clinical professions, so at the master's level in clinical, you are trained to diagnose and treat using the DSM. And so you don't have a limited scope of practice, which under the DSM, you would have training on addictions. And so that's why there were two different tracks for those master's and clinical level practitioners in the past. Either you had to have the bachelor's level with training in the addiction category, or you had to have the master's level or clinical level license where you would have already had training on those addiction topics as part of your education.
Okay. Thank you so much. Thank you, Madam Chair.
Committee, further questions of David? All right, seeing none, thank you very much. Appreciate it.
Thank you, Madam Chair.
Next, I have Michelle Ponce, Associate Director of Community Mental Health Centers of Kansas. Welcome to committee.
Thank you.
Welcome
Good
back.
afternoon. Thank you. Again, my name is Michelle Ponce. I'm the Associate Director of the Association of Community Mental Health Centers. We represent all 26 of the licensed mental health centers across the state. As you've heard from us many times before, our CMHCs are struggling with workforce shortages across the state. We completed an internal survey about a month ago, and we discovered that across the system, they're operating at about a 20% vacancy rate. We're very thankful to the legislature for passing legislation last year that establishes the Certified Behavioral Health Clinic model in Kansas, and we do believe that that will help our CMHCs become more competitive in terms of recruitment and retention. However, we still need people. We still need the qualified licensed professionals to fill those positions. We do believe that House Bill 2734 will lessen the burden on qualified clinical staff seeking licensure, therefore encouraging them to stay in Kansas and to enter the workforce more quickly. In conclusion, we support anything that will help expand and enhance our workforce and believe this is a welcome addition to the BSRB statutory process. Thank you for the opportunity to testify in support of this legislation, and I'm happy to take questions at the appropriate time.
All right, thank you. Questions of Michelle? All right, seeing none, thank you very much. All right, committee, that concludes our proponents. We do have a proponent written only for Nicola Sunday, CEO of Ember Hope Youthville. And so at this time here, that we'll close the hearing on House Bill 2734. Without objection, we'd like to work. Is there any objection to us going ahead and work in House Bill 2374? Or 2734? Yes. All right, Representative Epley. Whatever your name is. Doctor.
Dr. Dumas. Sorry, I couldn't help.
Yeah, we don't
We don't
know.
want to go into that story.
You haven't seen this
Madam
yet.
Chair, I would like to move that the committee pass House Bill 2734 out favorably for passage as presented.
You've heard the motion by Representative Epley. What?
Did we take a vote to, oh, no.
We don't have to.
We
There
don't-
was an objection.
We don't do that anymore.
Every committee does a little bit different. I just do it without objection because if someone objects, then we're going to. Seconded by Representative Kelly. Questions? Seconded by Representative Kelly. Questions or comments on the bill? Representative Barker.
Madam Chair, I find this to be a non-controversial bill. Would the chair consider putting it on the consent calendar?
If we were in the House on a regular basis, I would, but we're trying not to risk that kind of stuff right now.
Very well, thank you.
But yeah, it would have been a great bill for that. Thank you.
Great idea.
All right, seeing none, Representative Epley, you may close.
I close.
All those in favor of passing House Bill 2734 favorably signify by saying aye.
Aye.
Opposed, no. The ayes appear to have it. The ayes do have it. Motion carries. All right, now we will go ahead and go to, let me give all this stuff to Dave or I'll be in trouble. All right, now we're going to open up the hearing on Senate Bill 200. And again, we will have Reviser Scott Abbott review the bill for us.
Thank you, Madam Chair and members of the committee. Senate Bill 200 comes to you from the Senate Committee on Public Health and Welfare. The committee did make some amendments to change the wording and the contents of the bill. The bill would amend and expand the scope of practice for pharmacists licensed in the state of Kansas to allow them to provide certain testing and treatment of specified healthcare conditions. The version of the bill amended by Senate committee that's before you today, those conditions are limited to influenza, streptococcal pharyngitis, or urinary tract infection. The bill would also direct the Collaborative Drug Therapy Management Advisory Committee to adopt a statewide protocol for the treatment for each of those conditions and to consider certain factors as they develop the protocol for each of those conditions. The bill would also make some conforming amendments to the definition of the practice of pharmacy in the Pharmacy Act to conform with that expanded scope of practice and to make some clarification that the bill does not affect other substantive provisions of the practice of pharmacy. The bill would take effect upon publication in the statute book or July 1, and I'd be happy to answer any questions.
All right, committee questions of Revisor Abbott? Seeing none, thank you very much, Scott. Appreciate it. Okay, committee, we are going to open up the discussion on Senate Bill 200. Our first proponent is Elizabeth Patton, State Director of Americans for Prosperity. Welcome to committee. I will ask that proponents not read their testimony too, please. I'm sorry, I didn't do that.
Just making sure my microphone's on. Here we go. All right, thank you. Thank you, committee. Appreciate the opportunity to testify today in favor of Senate Bill 200. This bill has been around for a little bit now, and we feel like this is a great opportunity for Kansas to help lead the way in both increased access to care at lower costs, and the ability for Kansas communities to make sure that they are able to treat, give families and meet families where they are at, for healthcare. We think it's innovative. We have seen other states do something similar. In Idaho, really led the way with their bill. Montana, Florida, North Carolina, and New Mexico, who have also authorized similar policies. We have seen both an economic impact with pharmacists and pharmacy operations in their states. We have seen a better wellness outcome and an improved access to care. We think this is a very innovative opportunity for us. We wanted to applaud the pharmacists for bringing this forward, and would be happy to stand for questions at the appropriate time.
All right, we'll go ahead and do that now. Are there any questions for Elizabeth? All right, seeing none, thank you.
All right, thanks.
Next, I have testimony from Mitch DePriest on behalf of Kansas Association of Chain Drugstores. Welcome to committee.
Mitch DePriest, on behalf of the Kansas Association of Chain Drugstores, Madam Chair and members of the committee, thank you for allowing me the opportunity to appear here before you today. Our association represents more than 32,000 Kansans employed in over 500 pharmacy locations. Since the pandemic began, we have been proud of the ways that our pharmacists and pharmacy technicians and operations teams have stepped up, responding to changing preferences amongst consumers, a nationwide testing regime, and the millions of vaccines administered in Kansas and around the country. In this changing environment, we discussed how pharmacies could use their unique advantages in addressing other common health conditions. SB 200 is the product of those efforts that ensure Kansans are able to more easily address acute health conditions, including the flu, strep, or a UTI. Kansas pharmacies are already able to provide testing for these conditions through an FDA-approved process that identifies a test as being so simple as to render the likelihood of erroneous results as negligible, to the extent that they are often available for home use. SB 200 would enable pharmacists to treat Kansans at the point of care following a positive test while adhering to current clinical guidelines for those conditions. Finally, I'd like to add some detail to the considerable discussions outside this committee room. Following a hearing last year in the Senate Health Committee, a group of pharmacists and physicians met at the request of committee members to get a mutual understanding of how an agreement could be reached. The language before you today represents the great deal of compromise reached through those discussions as prepared by our pharmacy stakeholders. During Senate proceedings, the Medical Society expressed that changes nullified much of what they had previously raised in opposing testimony, and that they would present a clarifying amendment in the House. It is our belief, after having reviewed the clarifying amendment, that it is truly that, and we would not object to its adoption if that is the committee's desire or expectation that any statewide protocol adopted by the Collaborative Drug Therapy Management Committee was to include those detailed provisions. Thank you. I'd appreciate the committee's support.
All right. Committee, are there questions of Mitch? Representative Barker.
Thank you, Madam Chair. Great testimony. Yeah, I got a question.
Yeah.
UTI. Normally, they take a sample and they run it through the lab, and then they come back with whatever infection it is or whatever. Does the pharmacies have that type of equipment?
The CLIA waive process that I was alluding to, the FDA waive process, is not something that is commonly used by pharmacies, even though they are very effective at adhering to protocols, and through the pandemic have been proven to be effective with COVID testing. In large part because the patient would have to then go to a physician's office or their primary care provider to receive the same test, to receive the prescription for the therapy, and then go to the pharmacy again. So it's our intent is to be able to provide the test so that they could then receive the therapy at the point of care. That's the intent.
Okay. Thank you, Madam Chair.
Committee, further questions? Representative Wolf-Moore?
Thank you. And Judge Barker brought up an important point, and maybe Dr. Epley could help weigh in on this, but I didn't quite understand the answer, but
It's a
usually,
stick.
what?
It's a stick.
I understand, I get that, but usually then they do send it on to the lab to see which antibiotic they're sensitive to, so they provide the right antibiotic for the person who has the UTI. So how does that work in a pharmacist's office? Or maybe Dr. Epley can help us too. Thank you.
Without getting into the specifics, because I know there are multiple tests out there, and I can't speak to the clinical or operational side as well as some of the other conferees I know that will be following me. The intent of the test is that they are so simple that they could be administered at home. That's the idea behind the FDA's CLIA waive process. The testing processes and then the therapy initiation would be both outlined in the statewide protocol detailed in the bill.
Thank you, and thank you, Madam Chair. Maybe some other testimony will help shed a little more light on that for me. Thank you so much.
All right, Representative Lynn?
Thank you, Madam Chair. Do pharmacists need to have DEA numbers in order to prescribe?
So without getting into the details of some of the folks that may be following me, the amendment that I was describing specifically says the category of drugs and the drugs that would be approved. Our expectation was it would not be controlled substances, from what I understand. So they wouldn't have blanket authority to initiate any prescription. It would be specific prescriptions under that protocol.
So they are allowed to prescribe a non-controlled substance?
I'd have to plead a little ignorance off the top of my head. Sorry.
That's all right. Thank you, Madam Chair.
Representative Clifford?
Thank you, Madam Chair. Currently, vaccinations are done in pharmacies.
Correct.
So, I'm not familiar with all your rules. That's an injection into the body. Are there guardrails on injections into the body? I mean, we eye surgeons inject into the eye. So, are there the protocols have guardrails for, where in the body you can inject things?
If you're speaking specifically in terms of the statute and the location of the injections, I don't believe it is prescriptive in that manner. But I believe that they do have a statute saying that they are supposed to follow protocol in terms of if I receive an injection, there would be a process for making sure that I don't immediately walk out, but that is getting into an other area of statute that I don't recall off the top of my head, so I may be speaking out of turn.
I'll ask other conferees. Thank you, Madam Chair.
Committee, are there further questions? I think, one of them that I've had pop up with folks is how will the pharmacies then connect with the insurance providers so that people know whether they're in network or they're out of network with that pharmacy?
That's probably a good question. I not expected to be answered within the context of the pharmacy scope of practice legislation, but would be something that we would be willing to be interested in discussing outside this hearing.
All right, thank you. Committee, are there further questions? Representative Epley.
Thank you, Madam Chair, and I might defer to myself, but I'm going to defer to you, Mitch. And so you're up there, and so thank you for your report. And I've read this several times, and I'm still trying to understand and get on board. When you do a dipstick for your analysis, which is what we call it, you do a dip UA, and it's positive, for whatever reason, it's my girlfriend's spam. Just a second. Get rid of her. There. My question to you is, will those then be automatically set up for a culture and sensitivity, or not. I think that's a key thing for the group to understand. And I can't really, I've looked at the bill, I don't see that. That's customarily done, and through the protocol process, which is, codified, and I like that part, they're probably going to get on an antibiotic for 2 to 3 days. But then, is the CNS going to be set up on those? I couldn't tell from the language in the bill, and maybe someone else will address that. Maybe you know the answer. Thank you.
Yeah, in terms of the testing protocols, that would be something that would be detailed in someone, one of the following conferees may be able to give you specific details. Having considered the amendment from the Medical Society, I would say there's specific language in terms of current clinical guidelines, follow-up care. I think those might be some of the things that you would be interested in hearing about. But beyond that, I don't know if I can answer that at this time.
Well, I didn't mean to really put you on the spot. I think one of the other conferees will probably address it. It's probably covered in the language on the protocol, and I get that, but I don't know. It's just I'd like to see it spelled out a little better, but maybe my fears will be allayed soon. Thank you.
Committees, further questions? And we may have some as we wrap it. We'll go through our next proponent and see where we're at, Mitch. All right, next I have Amanda Applegate, Pharmacy Clinical Service Coordinator for Ball's Food Stores. Welcome to committee, and I'm not familiar. Where are your stores at here?
Yeah, so we have stores located, we're based out of Wyandotte County. We have pharmacies all the way up from Leavenworth all the way down to Olathe.
All right,
so
thank you.
13 pharmacies. We're from Ball's Food Stores. We run as Sunfresh, Price Chopper, and Hen House pharmacies. So for those of you in the Kansas City metropolitan area, you've probably shopped in one of our stores before. Pharmacists have long been one of the most accessible health professionals, with many pharmacies open extended hours, including weekends, et cetera, as well as operating in rural areas of the state. We see a lot of our patients on a monthly basis, or for those of us even more lucky to work where they shop, we see them 2 to 3 times a month, so very frequently. And I think for a lot of people, as was mentioned earlier by ks.gov, is that pandemic really opened the eyes to both the accessibility as well as the capability of pharmacists in the community setting. Our pharmacists are highly qualified healthcare professionals, so we have an accredited curriculum that looks at the education, identification, and triage of many common acute illnesses. I think not a week has gone by where one of our pharmacists, has a patient present to their counter and say, hey, I've got this going on, I've got XYZ symptom, or hey, I just got this number off of my home glucose meter, what should I do with it? And one of the points of the pharmacist is to be able to quickly triage that and say, is this something that I can help a patient answer? Or is this something that needs referral to their primary care provider, should they have one? Or is this something that needs an emergent medical call? So I think all of our pharmacies have wound up dialing 911 at some point, but a lot of what we do is look at that and evaluate, hey, is this something that we can do, or is this something that needs referred back to a higher level of medical care? For flu, strep, and UTI that these protocols are looking at, it helps really codify the pharmacist's response to that in terms of who can and can't be evaluated, and who needs that evaluation and higher level medical care than the pharmacist can provide at that community level. From there, the pharmacist would then be able to guide protocol-guided therapy in terms of looking at, into the question earlier about what types of antibiotics and things. I think one of the most commonly utilized pharmacists in the hospital setting, especially, is going to be those that can look at what type of bugs are available, in terms of what's being treated, and then what antibiotics are going to be appropriately utilized, what's going to be sensitive, et cetera, to that. So, and then also, as was mentioned earlier by the Americans for Prosperity, this isn't new in terms of statewide protocols for pharmacists. They're designed to really improve that access to care in a consistent and predictable fashion for patients across the state of Kansas, especially with those self-limiting and low treatment risk conditions too. We already have a couple of statewide protocols, especially looking at public health in the state of Kansas in terms of immunizations, as well as naloxone. And this would put us in line with several surrounding states such as Iowa, Idaho, and then other similar states such as Kentucky too. So they've allowed pharmacists to do this in a similar fashion for a number of years. I've been working on this idea and this protocol for about 5 years now, and I really appreciate the communication that we've had so far with other associations as well as the Kansas Medical Society. I think one of the primary things we've looked at is leaving some of these clinical decisions to the clinicians, and that's why we've managed to, have this already existing collaborative practice committee through the Board of Pharmacy that allows 3 pharmacists and 3 physicians to work on some of these clinical details in terms of what needs to be sent out for further testing, what's going to be, a referral process in terms of higher level medical care, as well as, if we're talking UTIs, what does need to be set out. So working on allowing those clinicians to work together to come to an agreement in terms of that outside of the legislative process. And that's something that we really appreciated that partnership on. So with that, like I said, I urge your support of this bill, and I'm happy to stand for some further questions that maybe haven't been addressed already.
Committee, are there questions?
Doesn't look like there's any.
Well, and maybe you can help me on some of the payment questions, which is I'm a little concerned with. I assume you're expecting insurance reimbursement?
In some cases, yes. I think in some cases, the pharmacists will defer to cash payment. But in some cases, if this is under the scope of practice, we would have the ability to bill insurance for this.
So you'll be contracting with insurance companies and not doing this under the PBM?
Correct. So the pharmacy benefits manager, the PBM that was referred to, would be what's standing between the insurance company and the pharmacy in terms of medical or medication and products. Contracting on the other side through basically billing a medical benefit wouldn't involve a PBM in that case.
Okay. So then in discussion with the patient or client, you're going to discuss up front what payment would be because there's an issue with in-network, out-of-network. As you said, it may be a cash type of a situation, so they're not dealing with any surprises.
Correct. So this would be similar to what you experience at the physician office or your primary care provider's office is that, hey, this is the expected payment. We are going to bill your insurance for it, and it's possible that we would have a copay after the fact. Or like I said, some pharmacies that already participate in this just do a cash-based model, so it's cheaper and easier for the patient in the long run in some cases.
Okay, because I think we get into credentialing and stuff when you go with the insurance companies and get in-network versus out-of-network. And
Yeah,
all those
absolutely. And that credentialing process is something that the pharmacists would absolutely be willing to go through.
All right. Then I'm going to hope we don't see a rate parity question brought up here in the next few years. Question, committee. Any further questions? All right, seeing none, thank you very much. Appreciate it. Okay, committee, that concludes our proponents. You do have, let's see, Kansas Board of Pharmacy, Alexandra Blasey, Aaron Dunkel, Executive Director, Kansas Pharmacists Association, Christy Krieghauser, Senior Director of Government Affairs, Kansas Chamber, Ryan Erzik, Public Affairs and Government Relations, Walmart, Morgan Button, Richie's Drug Stores, and Rob Tinsley, CEO, Curus. And then we have, those were your written only. Then we have opponents, and we have 2, Christy Clark, President of the Kansas Chapter, American Academy of Pediatrics, Dr. Jennifer McKinney, President, Kansas Academy of Family Physicians, and those are all written only. Is there anyone that expected to be called upon that I did not call upon? All right. Then we have 1 neutral, and we have Rochelle Colombo, Executive Director of KMS. Welcome to committee.
Good afternoon. Madam Chair, members of the committee, I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society, and I am happy to testify before you today on Senate Bill 200. And I have a lot of notes and I have testimony, but I thought maybe the best place to begin was with a little bit of background, because I think it's a little bit confusing without that. Senate Bill 200 was introduced last year by the proponents, and as it was written, it would have allowed for, and I think they refer to this as the point of care pharmaceutical bill, it would have allowed for a pharmacist to independently initiate treatment, which which is another word for prescribe. So to diagnose and to prescribe independent of a physician. And I think there's already been a lot of questions. It was as written originally in Senate Bill 200, they would have been able to independently initiate treatment for influenza, UTI, strep, COVID-19, and the other one was other self-limited conditions and/or as determined by the Board of Pharmacy. So the Kansas Medical Society opposed this bill based on the philosophy that, for one, the independent initiation of treatment includes diagnosing and prescribing. That is clearly the practice of medicine and surgery, which is limited to physicians. Number two, those tests and those conditions, some of us think of those as very straightforward indications. And yes, there's a dipstick, there's self-home tests for some of these things. While the test might be simple, a differential diagnosis is not. And just because you have a positive test on something does not mean that you have been ruled out for other conditions. Again, this is really ultimately the practice of medicine. And if it wasn't complicated, we could probably have a vending machine where we put in that we took a home test and we got a positive result and then we got a treatment for it. But we all know that there can be other conditions and other things that are underlying. And we felt that it was overly simplified. It was also brought forward on the basis of increased access and reduced cost. Some of the major proponents of this bill have also supported other measures for non-physicians to prescribe and treat medicine independently. And I would say to this committee that if those measures are to go forward, I'm not sure that there is a need for what was originally proposed in Senate Bill 200. Again, it's been framed as access and reduced cost, but you have some large corporate interests that are not located in rural areas looking to have more prescribers. And those things have been supported on other non-physician prescribing bills as well. However, with all of that said, we spent the summer months, and I would like to commend the proponents. They met with us, again, at the direction of the legislature, and we looked to say, can we find a way for clinicians to talk about what's actually necessary, and is there a way to proceed that does appropriately allow more access, or maybe some reduced cost, or some more convenience for patients that still protects the relationship that ought to be had between them and their provider. And you know what? I think they would agree with me. It was not always a pleasant process. We had a lot of meetings, and there were a lot of different opinions. But there is a goal, I believe, among pharmacists and those who are employing them, as well as among physicians, that patients ought to be well served and that they ought to get great care and that they should have access to it. And we spent from June through October meeting on those things. The Senate opted to work this bill, Senate Bill 200, before we had a chance to determine if we had quite come to any consensus. But we worked with the proponents at the point at which it was printed in the calendar to say, where are we and can we get somewhere closer to where we think we ought to be to protect patients? And I would like to thank them because they included at our request, they actually offered an amendment, we offered an amendment, but they were very close in nature. And that's really what was before you today in this printed bill. However, if you've looked at my testimony, what we agreed to, we had sort of a gentleman and gentlelady's agreement that we didn't feel that quite got to where we needed to go, that there was more work to be done, that some of the questions that have been asked by Representative Lynn and by Dr. Epley and by Dr. Clifford and as well as by Representative Wolf-Moore were not quite outlined, that again, this isn't a vending machine. We have to consider more than just is the test positive and what ought the drug be. We need to look at clinical indicators. We need to determine age. We need to say, have other things been ruled out? No, a pharmacist is not required to have a DEA number. No, they cannot prescribe on controlled substances. And if you look at it's right here in Senate Bill 200. If you look on page 3, lines 8 through 19, when they talk about collaborative drug therapy management, that's something that is currently allowed under current law. And this allows a pharmacist and a physician to work together so that a pharmacist has a little bit more operating independence to meet the needs of their patient. But it says right there that they cannot independently diagnose or treat any disease, prescribe drugs, or independently practice medicine and surgery. And it defines a physician as one who is licensed to practice medicine and surgery. I appreciate the fact that the proponents have kept this language intact. It's really important, and it respects the difference between the professions. What we have suggested together with the proponents of this bill is that rather than the underlying bill that was before you that just allowed them to treat on these certain conditions because they seem straightforward, that instead we do what was described by the last proponent. Let's let the clinicians get together. The statute already has a mechanism for that. It's the Collaborative Drug Therapy Management Advisory Committee. It's made up of 3 appointees by the Board of Pharmacy and 3 by the Board of Healing Arts. So ultimately 3 physicians, 3 pharmacists, they'll get together and they'll say, what should the criteria be? What is the training necessary? Who is responsible if under this protocol there's an adverse outcome? Because ultimately this is part of the practice of medicine. They will be independently prescribing based on an understanding of what the underlying condition is. And so we've offered, as is outlined in my testimony, some additional changes which the proponents have agreed to, which we believe better allow the protocol committee, which is the Collaborative Drug Therapy Management Advisory Committee, to define these protocols and to determine what is the appropriate way to proceed. So with all of that background in mind, what is actually before you, Senate Bill 200, what it would really establish is that the Collaborative Drug Therapy Management Advisory Committee may develop protocols for a pharmacist to then independently initiate treatment on these 3 conditions: UTI, influenza, and strep. And they will have to be agreed to, and then they will fall under the conditions of this amendment. We think that while we don't believe that the basis of this bill is necessary, I think that the work that's been done to make this better policy has been the right process. We really appreciate the proponents working with us. We know we have a shared goal of protecting patients, and that to the extent that the amendment that we are requesting in our testimony allows for that, we're able to move to a position of neutrality today. So I'm happy to answer any questions, and I again would like to thank the proponents for working together with us.
Thank you. I think neutral is a big move for KMS. Representative Barker.
Thank you, Rochelle. Great testimony.
Thank you.
In your discussions, and you kind of alluded to that, about age.
Mm-hmm.
You know, you can bring an infant in who can't really tell you what's going on.
Mm-hmm.
Or if you bring an 18-year-old walks in the door, they can have a conversation.
Mm-hmm.
So was there ever consideration of an age limit that they would be able to do that? And if so, what happened to that?
Yes, so that was, so in the, if you have a copy of the bill before you, that's, and this is why I wanted to go through the several steps, because you have the original bill, you have as amended that came from the Senate. As amended from the Senate, age is one of the criteria that the protocol committee would have to consider.
So they would decide that?
Pardon me?
The protocol committee would decide that?
Yes, and we're further requesting an amendment to go actually beyond age, to say age is of course a criteria, but it's not just limited to age.
Okay.
Thank you.
Thank you, Madam Chair.
Representative Lynn.
Thank you, Madam Chair. Has this committee met yet?
They meet, they're already established in statute because they are the committee that looks at the 1-to-1 ratio or the relationship between pharmacists and physicians. So they meet on kind of an ad hoc basis, but they already exist in statute.
Do you know if they've discussed what the protocol would be for the biohazard waste as a result?
No, they haven't. They're not meeting now. They would have to, so probably new committee members would have to be appointed or updated for them to consider this. But no, I don't believe so.
But you would imagine that there would be a protocol established for biohazard waste.
This doesn't require that. What this requires is protocols only. The only thing that this allows for is protocols to treat these 3 conditions. It doesn't establish a protocol for biohazard waste. No.
Given that there would be some.
Yes.
Okay. All right. Thank you, Madam Chair.
Further questions? Representative Blacks.
Thank you, Madam Chair. Thank you for being here. The collaborative practice agreement, would that be a universal situation, or would that be between the pharmacist and a doctor, or just a local little group of individuals?
So this doesn't change that. That already exists in statute. So what you have, and that's what I referred to on page 3 of the bill in lines 8 through 19. So already there is an allowance. So there's the normal operating procedure between a pharmacist and a physician, where a physician may prescribe and they direct the treatment, and a pharmacist may dispense. But if you want to have more flexibility between a pharmacist and a physician for them to, let's say, adjust number of days or a variety of things, there is provision already in state law for collaborative drug therapy management, and that is through an agreement between a physician and a pharmacist, and it can be a physician and any number of pharmacists, or it can be one-to-one. But this doesn't change that at all. That already exists in state statute.
Okay, thank you for clarifying that.
Are there further questions? Representative Marburger.
Thank you, Madam Chair, for calling on me finally. Rochelle, I have a couple questions. One, as Senate Bill 200 was introduced, you guys were opponents. As amended in its current form, you're neutrals. And with this language that you have in your testimony, you're even a stronger neutral?
That's a great question. I appreciate that. So I would say that we moved, yes, we were opposed as it was introduced. We came to an agreement as it was moving out of the Senate. Again, it appeared in the calendar, and candidly, Mr. Monroe and I had a conversation to say, is there a way that we can get closer to what our committee was working on? And we agreed that there was an amendment. It wasn't perfect, but we had about 6 hours to get it done. And so the agreement was, we'll get to neutral, but let's agree to continue working on this as it moves to the House, because we think it could be a little better, but we really don't have the time to get it revised. And that allowed them to move forward, and there was a good faith agreement that we would respect one another's boundaries on this issue. So we're not more neutral or less neutral, but we did stay neutral. And I think had either side not honored that compromise or that agreement, it would have been a different place. But we really feel like their approach to this policy, though we didn't agree to the underlying premise, did respect clinical differences, and we appreciate that.
Okay, and my follow-up question is, it's just to treat influenza, strep throat, and UTI. Did you guys have conversations on these are the major 3, or was the list much larger and compromised on this?
That's a great question. There were extensive conversations about that, because the underlying bill, again, allowed for those 3 plus COVID-19, which we could all have a long discussion about whether that's self-limiting or not, or easily diagnosable. And then it also said, or other conditions as defined by the Board of Pharmacy. And we did not support that, because we felt that would have been much broader and would have left physicians out of determining what could be. There was a discussion about CLIA waived test and all of that. But what were appropriate conditions to be allowed for in statewide protocols? So yes, we believe it went from pretty much everything down to these 3 conditions, and now this just allows the protocol committee to determine what needs to happen on these 3 conditions.
Okay, thank you.
Committee, are there further questions? Rochelle, I just want to say thank you for your willingness to work as well as John and Mitch, and this is how good policy happens. And because mistakes can happen if we don't have multiple eyes looking in on this, so it wasn't rushed through. So I definitely appreciate that work a lot.
Well, thank you very much, and I would thank them as well. All the groups, I mean, they had clinicians, we had clinicians, and they worked very hard, and it's not very fun work to do, but we did share a common goal, and I appreciate their effort to that.
All right, thank you very much. All right, committee, that's all that I've got on Senate Bill 200, so we'll close the hearing. Any objection to working Senate Bill 200? Seeing none, Representative Eppley.
Yeah, no.
Oh, no.
Amendment first, right? We're going to do the bill first.
Either way you want to do it.
Madam Chair, I guess we'll go in order of the amendment first and then the bill. And so I would like to offer up an amendment as proposed here, as brought to us on Senate Bill number 200. As outlined, there are 3 balloons here. Basically, the big balloon is developing statewide protocols as outlined in 4 situations. And I think he's going to pass those out now. And I hope for a second on this amendment. Second by Representative Kelly. Give him a while to look at it.
Motion by Representative Epley, seconded by Representative Kelly on the amendment. John, you've seen it? Mitch? Rochelle, you've seen it?
I have not seen it.
Would you please? Representative Arnberger.
Thank
On
you.
the amendment.
Thank you. Madam Chair, my question is for the reviser. I just want to clarify, is this amendment in front of us the exact language in KMS's testimony, what they're trying to achieve?
Madam Chair and Representative, in substance, yes, there is one or two places where to conform with Kansas statutory style, I may have changed a word, but otherwise it should be identical.
Thank you.
Further questions or comments on the amendments? Representative Blex.
Thank you, Madam Chair. On item 4, where communication requirements, including but not limited to notification of the patient's personal or primary care provided, is that prior to filling this or after? When I don't see a timeline on that.
Rochelle?
The intent that would
Okay,
be,
state who you are and who you're with each time, please.
pardon me, Rochelle Colombo, Executive Director of Kansas Medical Society. The intent would be that would be afterwards, that once the protocol was executed, they would communicate back to the primary care provider, not prior.
Thank you.
Further comments or questions on the amendment? All right, seeing none, Representative Epley, you may close on the amendment.
Madam Chair, I close.
All those in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries on the bill. Representative Epley.
Now, Madam Chair, on the bill itself, I would like to ask that the committee move Senate Bill number 200 out favorably for passage as amended.
All right, you've heard the motion by Representative Epley, seconded by Representative Kelly. All those in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Okay, that is all that we have for today. And I think we're on call tomorrow, isn't that correct? So I would highly recommend that keep your ears open and watch your agendas as they come in, because we still have the bill from last week that we asked parties to go back and work on, and they were trying to have language to the reviser today. It may not get to the reviser until in the morning. And as soon as he's got that ready, we will get back in here and work that bill. So are there any other things before this committee? Seeing none, we are adjourned.